بسم الله الرحمن الرحيم. الصلاة والسلام على سيدنا محمد، أفضل الصلاة والتسليم، حبيبنا ومعلمنا وقدوتنا صلى الله عليه وسلم. في المحاضرات الماضية تم تقديم موضوعات الهايبوناتريميا، جميع حالات الهايبوناتريميا وكيفية التعامل مع أي حالة هايبوناتريميا، ونسألكم الدعاء بالتوفيق لمن استمع المحاضرات دي واستفاد منها إن شاء الله، أن تكون الهايبوكاليميا مقدمة بطريقة مبسطة وأسهل. الغرض من تقديم المحاضرات ان انت قابلت اي مريض او تعاملت معاه في اي مكان، ازاي تشخص المريض صح وازاي تعالج المريض صح بدون اي مضاعفات للمريض، والله المستعان. ودايما نسالكم الدعاء بالتوفيق. اليوم هيتم بدء اول محاضره في الهايبوكاليميا. حاولت نعملها في محاضره واحده بس لقيت الوقت هيكون طويل وهيكون ممل. ان شاء الله نحاول نقدمها بطريقه مبسطه وطريقه سهله، ونحاول نغطي جميع اجزاء الهايبوكاليميا اليوم ان شاء الله باذن الله. ولا تنسونا دائما بالدعاء بالتوفيق والسداد. اليوم هنتكلم عن الهايبوكاليميا كلينيكال او براكتيكال ابروتش. ده الكلينيكال ابروتش الموجود في برينر، تمام؟ ترولوجي تكست بوك. الابروتش will start by definition of hypokalemia in potassium less than 3.5. The first step when you see a patient in your clinic or consult or patient on ward already, please just take good history from the patient. From the history you can diagnose any diagnosis. The patient give you full details of history and focus on the drugs. First thing, just check your history. Second step, taking medication with the patient. What some medication can do this electrolyte problem or disorder. GIT symptoms, renal disease, blood pressure. Blood pressure is most important in hypokalemia. You will see later. And weakness, during the examination you will find your patient weak or no, because most of our patients will came by muscle weakness and paralysis. Physical exam, focus on volume assessment and the blood pressure. This patient effective arterial blood volume or intravascular volume depleted or no. The blood pressure is the most important also in our patient. Hypokalemia, when you see in a consult with patient with hypokalemia, please history, medication, don't forget the medication is the most important. And any GIT symptoms, nausea, vomiting, diarrhea, this will help you to diagnose your patient. Renal disease will help also you to diagnose your patient. Blood pressure, hypotension, hypertension, normotension. Any patient's weakness, paralysis, to deal with is your patient emergency or no. Physical exam from A to Z, from head to toes, and focus on volume assessment your patient, hypovolemic, euvolemic, hypervolemic, and the blood pressure of your patient. What I will send in when you receive in a consult, please just be sure before you will see your patient you have stat lights, even the here previous one. Please ask for new stat lights and ABG or VBG with lights and other electrolyte. Magnesium is the most important in hypokalemia, because if you have hypomagnesemia, you should correct first or with a correction of hypokalemia. Otherwise, you will give potassium and you will lose through from the channel, renal outer medullary, magnesium channel, potassium channel. You will lose potassium from this channel if you have deficient in your magnesium. Please also, if you have your patient hypertension and hypokalemia, don't forget spot sample of renal aldosterone and renal aldosterone ratio. Renin and aldosterone spot sample, blood sample. And don't forget urine is the most important, and we'll see later why. And urine osmolarity, creatinine, check your patient in AKI or no. And the calcium, urea is the most all important electrolyte you need. And when you ask any patient for calcium, don't forget to ask for albumin. Any calcium, because of our nephrologist, any calcium, we need to ask for albumin, because if you have low albumin, you need to correct your calcium. And the 24 hours potassium, creatinine, lights, osmolarity. You like if you have this facility, you can do this. Otherwise, you can do all spot sample in urine. As regards this diagram, we have many causes for hypokalemia. either decrease intake. Decrease intake alone is not enough to do severe hypokalemia. The most main topic in hypokalemia will talk shift or loss. We have potassium shift inside intracellular fluid compartment or inside cells, or potassium loss. Potassium loss either extrarenal or renal. And with regard to potassium shift, when you think your patient with acute hypokalemia, with acute problem flaccid paralysis, and you just will check urine lights, urine potassium, urine creatinine, and we'll come to this later. And we'll discuss this in details by today. And otherwise, if your patient have loss, either shift, is the main topics, or loss. Loss, just will think this extrarenal or renal. And we'll discuss this in details too, because I need you to be, don't forget any classification or any diagnosis or misdiagnose your patient. Just when I throw any consult for hypokalemia, please put in your mind this shift or loss. And we'll come by details. We'll discuss today now how to diagnose your patient with acute hypokalemia is this patient shift. And this will continue next, but this is continue our diagram, and we'll discuss. I will not need to confuse you or disturb you. Just this diagram, just to keep in your mind. We'll discuss each point by details. This other diagram already done by Dr. Abdelhamid, some micro hospital. This is a nice diagram if you will follow. Regarding a patient also with hypokalemia. Now, just first step, we'll check hypokalemia means less than 3.5. Just to check urine potassium, urine creat, spot sample, and if this less than urine potassium divided by urine creatinine, if less than 2 or more than 2. Less than 2, this is our discussion today. We'll discuss this part. If less than 2, just check acid-base disturbance, any acid-base disorders or no. No acid-base disorders and urine potassium create less than 2, this means acute shift of potassium to inside the cells or full intracellular fluid compartment from extracellular. This is our discussion today. We'll concentrate on this at this point. If urine potassium to creatinine less than 2 and there is metabolic acidosis, is this metabolic disorders? If yes, so what is type of your metabolic disorders? If high metabolic acidosis or metabolic, if you have metabolic acidosis or you have metabolic alkalosis. If I have metabolic acidosis, just put in your mind the most common cause is diarrhea or GIT loss. If metabolic acidosis, just don't forget to remove diarrhea. He's taking Lasix or furosemide last 2 days, last 3 days. Just put this in your mind, or patient with chronic chloride salt hosting diarrhea, patient loss from the skin cystic fibrosis, all this extrarenal loss, all this will come by this metabolic alkalosis. The most important here, just to concentrate, is this patient with removed diuresis. Okay, otherwise, if your potassium, urine potassium to urine creatinine is the last update standard by 2021. Standard protocol for hypokalemia. This is already updated more than protocol. If your urine potassium to urine creatinine more than 2, we'll check acid base. If your patient with acidosis or metabolic alkalosis. My patient with hypercholoremic metabolic acidosis, we have differential diagnosis here. Either diarrhea, distal RTA, and other differential diagnosis you can read. If you have this patient with metabolic alkalosis, we need to check the blood pressure and the intravascular volume compartment. Is volume depleted or volume overloaded, and the blood pressure. Blood pressure is the most important with metabolic alkalosis. If I have hypokalemia and this acid-base disturbance with metabolic alkalosis and the urine potassium to creatinine ratio more than 2, this means renal loss already, and we'll go to check the blood pressure. This high blood pressure or low blood pressure. Okay, and regarding the high blood pressure, we'll discuss this in detail in next presentation. Just we'll differentiate this between primary hyperaldosteronism, Cushing, and Riddles. We'll see if this patient with low or normal blood pressure. So we'll go to this differential diagnosis according to urine chloride. If you is low, the patient was vomiting. The urine chloride resistance high is with our rare congenital syndrome, Bartter syndrome, Cushing syndrome, or acquired Bartter or Jeter syndrome. The intermittent high, low, this means with diuretic. This diagram is very nice diagram to guide you. When I am consulted to any patient with hypokalemia, the first step, please just ask for this. That you can repeat statin lights as we said before. And don't forget to send the urine creatinine, urine potassium ratio, because it will take you either this side or this side. The urine creatinine, urine is put urine sample if less than 2 or more than 2, and if less than 2, either with acid-base disturbance, will go to diarrhea, remote diuretic, or if no acid-base disturbance is acute shift, and we'll discuss today in details. If your urine creatinine potassium ratio more than 2, you check as the next step, we'll check acid-base disorder, this patient metabolic acidosis or metabolic alkalosis. Metabolic acidosis, we have diarrhea, RT is the most common, and then if metabolic alkalosis checks the blood pressure, hypokalemia, urine potassium to creatinine ratio more than 2, metabolic alkalosis, high blood pressure, we should check renal aldosterone, and will come in this by details. If it is low blood pressure or normal pressure, just if you have a history of vomiting, okay. If you have persistent high chloride, we'll check urine chloride. If it's low, this is vomiting. If it's resistance high with congenital syndrome, Bartter or Gentleman syndrome, the urine chloride intermittent high and low, not fixed. This means patient may be on diuretic. They will concentrate on this diagram because it's easy and simple and not more confusing. I need you to forward any other diagram. This is the last of the diagram updated already by Dr. Kamel. This an old man in electrolyte and acid base. I think he's spent all his life in this chapter of nephrology. What is normal potassium balance? As regards just to back to physiology, just I will not talk in details. Just I need you to know what is the dietary intake daily. We are taking daily around 80 to 100 milliequivalent per day. This is our dietary intake from potassium. What is excretion? We have excretion either from kidneys or from stools. Will come now as regards the fecal excretion around 8 to 10 milliequivalent per day, and the urine excretion from 70 to 90 milliequivalent per day. And we have other way to lose your potassium through intracellular shift. Our shift today, this patient already received the insulin, beta-2 agonist, and we'll discuss this in details today. This is our intake, and this is our loss, either this kidney or GIT or shift. What causes of hypokalemia? What is causes? You should put in your mind, your patient decrease on intake. I will keep this in my mind, but you should think this shift or loss, GIT or renal, okay? This, we are taking here our intake 80 to 100 milli, and we'll check GIT, and we'll check urinary, and we'll check this. We have 3 parts to check hypokalemia, either shift, either GIT loss, either renal loss. Shift, renal, GIT, and this our intake. So now, potassium deficient, this is the symptoms of hypokalemia. Some became by weakness, fatigue. You know, our hemodialysis patient, when not this common with hyperkalemia, not with hypokalemia, that will come to muscle weakness, fatigue, paralysis, but also with hypokalemia, the same symptoms with arrhythmia and tachycardia. You know, if you go back to cardiology, for sudden cause of cardiac arrest, hypo or hyperkalemia. The arrhythmia lead to, especially with hypomagnesemia, to SADA deep point and the ventricular tachycardia and the arrhythmia and sudden death and stall at the end. And these all symptoms you can read to. We'll start today by the case number 1. 45 years old man came by to emerge or to your clinic or to whatever you will see your patient, or you consulted for this patient, 45 years old man with severe muscle weakness, paralysis. Muscle weakness, paralysis, just check all electrolytes for this patient. With no history of vomiting or diarrhea or diuretic. No vomiting, no diarrhea, no diuretic. Vomiting, diarrhea, diuretic, none. No history of hyperthyroidism or thyroid periodic paralysis or hyperthyroid periodic paralysis. No history of hyperthyroidism, thyrotoxic periodic paralysis, sorry. And two similar episodes over the last year happen already on the last years, the same episodes of muscle weakness and paralysis, and no family history of any disease or familial disease. Blood pressure for him, the blood pressure is little bit your normovolemic or normotension, 150/70. Heart rate is 90. Neurological examination, we found your patient on flaccid paralysis. The patient can't raise his limbs or upper limb or lower limb. And we already did ECG, just you show U waves, and we'll see now. And regarding his plasma sodium is normal, 140, potassium 2.1, and bicarb 25 is okay. What is your next step for this patient? I will go to investigate, or you should go to treat. Emergency is emergency. What is emergency in hypokalemia? Most common emergency in hypokalemia when you check your ECG, cardiac problem and muscle problem. It's the most two side effect or complication of hypokalemia. I need you to put in your mind the most critical point in any patient with hypokalemia, cardiac and the muscle. Field examination, patient is weakness, paralysis, is emergency for him. If examination you found ECG with abnormal rhythm or arrhythmia, whatever, this emergency should be. The first step, my plasma sodium 2.1 is emergency or no? If it's emergency, just treat first. If you have patient at night and hypokalemia, just treat first and continue your workup later. The most important life-saving now. Okay, what is emergency? As I said, cardiac arrhythmia or respiratory muscle weakness or fatigue. This ECG signs you will see in this T wave and the QRS, and these T waves and these U waves. Is the U waves after these two T waves. With B and this PDU wave or prominent U wave. Okay, this is a signs ECG for hypokalemia. And again, this is prominent U wave after T wave. Okay, this is shallow T wave. And this U wave prominent here. And you know, PRS complex. And this T waves and this U wave is a sign of hypokalemia. Again, T wave here. And this U wave, sign of hypokalemia. And this clear, and this is a T wave, and this U wave you will see in patients with hypokalemia. What is the consequence of hypokalemia? This hypokalemia on our heart, we will see ventricular premature speed, ventricular tachycardia, and ventricular fibrillation, and this asystole and the cardiac arrest. This is the risk of hypokalemia. You should manage first and then investigate or do your all workup later to reach your diagnosis. This patient, especially if also hypomagnesemia and also on digoxin risk for this arrhythmia, if this patient was, as I said before, hypomagnesemia for torsada T point. Digoxin also will be complicated by this arrhythmia if patient on digoxin with hypokalemia. This will precipitate digoxin toxicity. This relation to this reduced competition between potassium and digoxin for this binding site on the cardiac muscle sodium potassium ATPase. It's a competitive inhibition for this sodium potassium ATPase in patients with hypokalemia and digoxin toxicity. ECG changes, you will see broad flat waves as we see in the last ECG, and ACT segment depression, broad flat wave, ACT segment depression, broad flat wave and ACT segment depression, and QT prolongation. Q is the Q, and this T you will see prolongation, and the prominent UF you will see also your ATG في البوتاسيوم less than 2.5 or 2.7. When you examine your patient, is a cardiac examination or cardiac signs of hypokalemia. And this muscle, when you examine your patient, you will find your patient flaccid, weak, unable to move, unable to speak. This is respiratory muscle weakness. You know, the differential diagnosis from rhabdomyolysis, the most common also is hypokalemia. Hypokalemia can lead to rhabdomyolysis too. We'll discuss this special presentation. In our kidney, what is the effect of hypokalemia or complication of hypokalemia in our kidney? Intracellular acidosis. Because when you have extracellular hypokalemia, extracellular, as we defined before, intravascular and interstitial. How it's the cell. When we have hypokalemia, how it's the cell, and this lead to more. This hypokalemia, how it's the cell, the potassium will go to intracellular, and sodium will go outside. As we discussed before, regard the hypokalemia, the sodium will go inside and will take the water, and the potassium will go from inside the cells to outside too, because we have extracellular hypokalemia. Potassium will go out because mainly we have this potassium inside our cells. The main second cation in our body, mainly intracellular around 140, and the potassium out the cell around 4 to 5 milliequivalent per liter. We have hypokalemia inside your blood vessels, extracellular. You will draw potassium from the cell, and you will replace this by sodium and hydrogen or water. And this lead to increase your intracellular acidosis, and this lead to secrete more ammonia and reabsorption more bicarb, so lead to metabolic alkalosis from this mechanism. We have now inside our blood vessels, this blood sample you take, hypokalemia. What is the mechanism of our body to deal with hypokalemia? We will take potassium from inside the cells, intracellular fluid compartment. This potassium will go from inside cells to extracellular, intravascular, to compensate this hypokalemia. To electron neutrality, just will take sodium and hydrogen to be inside the cells. Lead to little bit hyponatremia and intracellular acidosis. When the acidosis increases inside the cells, will excrete ammonia, and the body or tubule, the kidney tubule will sense that we should reabsorb more bicarb for this. It changes ammonia and this intracellular acidosis and lead to metabolic alkalosis. The mechanism of potassium and hypokalemia and metabolic alkalosis. Okay, and all this here already. We know stimulate ammonia production and to reabsorb more bicarb. In all hypokalemia, the cause of hepatic coma, hepatic encephalopathy in patients with liver cirrhosis, and also lead to interstitial renal disease, and nephrogenic diabetes insipidus is the common cause of this disease, hypokalemia. Pancreas also inhibit insulin release, because it's related to sodium potassium ATPase channel, and lead to hyperglycemia. For case, the patient came to emerge by flaccid paralysis, and no history of vomiting or diarrhea or any other medication, diuretic. This sodium is normal, potassium 2.1, and the bicarb or metabolic acid-based disorder, I think, is normal. And urine potassium creatinine, urine potassium is 10 millimole per liter, urine creatinine 10 millimole per liter. I will divide 10 over 10. This means urine potassium to urine creatinine less than 2. This potassium shift or no. To decide this patient with potassium shift or no, or loss or other, we need now to know acid-based disorders. As we know, acid-based disorders, Already here, I think this is normal acid-base disorders because either bicarb is okay and the other pH I think is normal, 7.35, and CO2 is normal, 45. This patient already was normal acid-base disorder. Now, because why I'm asking for shift or no? Because if the patient was shift and you will treat him with hyperkalemia, you will go to rebound hyperkalemia and after that. And to think to give him non-selective beta blocker, at least to decrease amount of giving more potassium IV. Non-selective beta blocker like propranolol will impair this issue for hypokalemia. And the sympathetic activity, adrenergic surge, and we'll discuss this in the next slide. Hypokalemia, just to put in your mind, either shift or loss. This is a broad classification to put it in your mind. This patient with shift need to replace by huge amount or loss, GIT or renal or skin. We have three sources for loss: potassium, skin, especially in patients with cystic fibrosis. With the respirology team. Respirology, if you call you for patient with hypokalemia and the patient already with history of cystic fibrosis, you just think your patient your loss in potassium so sweet. Or if the patient came by gastroenteritis, nausea, vomiting, diarrhea, just think your patient also lost through GIT. This patient with renal impairment, just think patient lost through your kidney. The first step. Second step, just check the potassium excretion, potassium to create ratio to decide less than 2, I will go here, more than 2, I will go here. Potassium to create ratio in urine. Assess kidney response. This is our normal kidney would expected to excrete around less than 20 millimole potassium per day. This is our kidneys. Urine potassium to urine creatinine, I will divide this 20 by urine creatinine in normal person. Urine creatinine normal person excretion around 10 millimole per day. You assume your kidney secrete 20 millimole potassium. Minimum divided by 10, less than 2. Less than 2, I am with shift now. Not loss, loss more than 2, either GIT or renal. We'll go to this algorithm. This nice algorithm I told you, just to remind, keep this algorithm in your notes. It is updated by 2021. What is urine potassium create ratio? Less than 2, more than 2. More than 2, we'll discuss later. Now we'll concentrate if less than 2. Any metabolic acid-base disorders? If no, I am with acute shift now. If yes, what is this acid base? This acidosis, diarrhea, or alkalosis, remote diuretic, or patient with laxative, or chronic diarrhea, cystic fibrosis, all this to put in your mind. Either acidosis or alkalosis, just to remind you by this remote diuretic use. Acid-base disorders, don't forget this. If you think your patient shift, the second step, acid-base. But only some caveats. What is this caveats? كل قاعدة شواذ. We have loss and already our renal urine create potassium sometimes less than 2. We can expect this patient just with acid base less than 2 urine potassium to creatinine, and you are already acid base. If on metabolic acidosis, you expect your patient with diarrhea, extra renal loss. If you expect your patient with alkalosis, this means maybe your patient with yesterday renal potassium loss on diuretic, patient received diuretic already 1 or 2 days back, and he's already metabolic alkalosis, and his urine potassium to creatinine ratio sometimes will be low. This whole good history will guide you to manage your patient and to give the appropriate treatment for our patient with hypokalemia. This caveats for urine potassium to create less than 2. The patient with acid-base disorders and diarrhea, this is with metabolic acidosis, and the patient with diuretic, on diuretic, this will give you the possibility of acid-base disorders to be in way of metabolic alkalosis. Hypokalemia, just to check acid-base disturbance after potassium to create ratio and decide the shift or loss. Now we have first step, we are dead in our patient, urine potassium to urine create ratio is low, of metabolic acid disorders, we'll see our answer now for this our test to guide us to manage and treat our patient. If urine potassium, urine creatinine is low, if yes, low means shift. Low means less than 2. We have shift now. The acute hypokalemia due to shift potassium in 2 cells. No metabolic acid disorders. Okay, with this to be diagnosed your shift. If yes, if this is low and we have metabolic disorders, we have, as I will discuss this caveats. This may be patient extrarenal loss with diarrhea or remote renal loss with diuretic. If just to clarify the previous point, if we have urine potassium, urine creatinine less 2, and we have metabolic disorders, just check this diarrhea and remove diuretic use. If your patient with urine potassium, urine creatinine low, no, not low, more than 2, and the metabolic acid disorders, yes, this patient chronic hypokalemia renal loss. This one last one, renal loss. This clear shift, this clear renal loss, and this caveats of this urine potassium to creatinine less than 2, yes, with metabolic disorder, they should think in diarrhea or diuretic. For case, plasma sodium 140, potassium 2.1, bicarb 25, and this urine potassium to creatinine less than 1, is clear potassium shift. There was no acid base, no acidosis here, bicarb is normal. Okay, so this is our diagram again. In patient with hypokalemia, urine potassium to creatinine less than 2, more than 2. Less than 2, we'll check second step, acid-base disorders. If no acid-base disorders, this clear shift. Take care when you manage your patient. Don't give more potassium because you will go to rebound. Just try to control the course. If it's yes, less than 2, and we have acid-base disturbance, is acidosis or alkalosis? Acidosis, diarrhea, alkalosis, remove diuretic use. Second step, we have now potassium shift. I diagnose my patient potassium shift. Second question, I will ask myself, is patient with high adrenergic surge or no? If yes or no, we'll answer this question. What means by high adrenergic surge? How can I diagnose this high adrenergic surge? Systolic hypertension, wide pulse pressure. What means by wide pulse pressure? Is wide distance between systole and diastole. And the patient will be tachycardia. It's high adrenergic surge. Just to continue to diagnose, to reach my diagnosis, if I reach to my patient is potassium shift. Second question, high adrenergic surge, yes or no? If it's high adrenergic surge, what means by high adrenergic surge? Systolic hypertension, wide pulse pressure, wide distance between systole and diastole, and tachycardia. Potassium shift, high adrenergic, yes or no? If high adrenergic, yes. If your patient using the beta-2 adrenergic agonist, if your patient under stress, CNS, heat trauma, subarachnoid, hemorrhage, MI, if your patient receiving drugs like amphetamine, ephedrine, just all this, with all this patient all with beta-2 adrenergic agonist. If your patient alcohol withdrawal, if your patient on caffeine overdose, if your patient insulin intake or sodium bicarb, just also if your patient looks with signs symptoms of thyrotoxicosis, you should think in thyrotoxic periodic paralysis. Now I reach to my diagnosis, potassium shift with high adrenergic now, yes or no? If it's yes, I will think on this, my differential diagnosis is I have criteria for high adrenergic surge, systolic hypertension, wide pulse pressure, and tachycardia. I should go to this table. You will think this is your patient in beta adrenergic agonist and patient stress, sympathetic nervous system, whatever, heat trauma, subarachnoid, hemorrhage, MI. Any drugs, amphetamine and other drugs, beta-2 adrenergic stimulant also. inhibition with alcohol, agitated alcohol withdrawal, inhibition taking too much caffeine, patient receiving insulin will do shift for that, will present one case for that also. The patient will take in sodium bicarbonate to correct acidosis, and already the patient with hypokalemia, the patient with signs and symptoms, cirrhotic periodic paralysis, and we'll discuss later. If I don't have criteria for high adrenergic surge, I will see this scenario with familiar periodic paralysis and sporadic periodic paralysis, potassium channel blocker, barium sulfide. Barium sulfide is a shaving cream. A shaving cream, when you are sniff or swallow this cream, your patient will come to paralyze, to emerge, especially in Parkinson patient. Now, with this no hydroenergic, this barium sulfide, maybe you will come to an exam and they will just give you a history. This patient just swallowing this barium sulfide and the patient came paralyzed to emerge. This acute shift to potassium to intracellular from extracellular. Metabolism, if you have patient already post-DKA treatment, will go to hypokalemia by this mechanism, or patient with pernicious anemia receiving B12 management, all this may be differential diagnosis for hypokalemia. Okay. Our patient already, when we are taking history from him, is taking a lot amount of caffeine already, and also drinking this Red Bull, this as energetic drink, taken to give him wings to fly, but already against will be having, he will be paralyzed from this caffeine intake. This each bottle contain around 85 milligram per kg. Now this is our example for shift here, as we mentioned, caffeine overdose. Okay, will lead to hypokalemia and muscle paralysis, hyperrespiratory paralysis, even this cardiac arrhythmia. If you are taking more caffeine, and if you are drinking this, just check what you are drinking as energetic drink, because sometimes it will contain high amount of caffeine and lead to hypokalemic periodic paralysis, even cardiac arrhythmia and death. Take care from this energetic drink. What is this mechanism of it? We have already our brain cells, we have adenosine already bind to his receptor A to receptor 2 on the brain and cell membrane, and just do inhibition for catecholamine. But already caffeine looks like adenosine. It will bind to A2 receptors to our brain cells and lead to increased catecholamines. And this catecholamines will lead to higher adrenergic surge and increased risk of hypokalemia. As we mentioned, this our diagram, we will discuss hypokalemia. Just first step to remind you, hypokalemia less than 3.5. First step, check urine potassium to creatinine. If less than 2, more than 2. We'll discuss today less than 2, just check acid base. If no acid base, just shift, acute shift to potassium. If more than 2, if you just check acid base. If acid base with acidosis is with diarrhea, if with alkalosis, just think all this chronic cause of diarrhea or diuretic use. Case number 2, we have 30 years old male with polyuria polydipsia and his blood sugar 28 millimole per liter, and an iron gap is high, hyperglycemia, polyuria, polydipsia, 30 years. 17 on iron gap, and urine ketone is positive, serum potassium 3.7. Admitted to hospital and started insulin sub-Q. We have now 30 years, polyuria, polydipsia, blood glucose 28, and iron gap 17, urine ketones is high, urine potassium 3.7, admitted to hospital and started insulin sub-Q. Next morning, your potassium consult nephrology for potassium less than 2.5. First step, this emergency or no, you will treat or no. Just check your ECG. If you will see any signs of hypokalemia or arrhythmia, just and check his potassium shift or no. How you know, just for metabolic, this patient already metabolic acidosis, but he received insulin now. And we mentioned before, in this table, we have insulin here. If you have potassium shift with high adrenergic surge, you just don't forget this insulin. The cause of shift also bicarb and cytotoxicosis. This all will do high adrenergic surge and lead to potassium shift. Now we have potassium shift from insulin use. What is the mechanism? When the insulin use, they will activate this sodium-potassium ATPase channel. We have two ways to do hypokalemia when we are using insulin in hyperglycemia patient. I give insulin, all this cascade will be having lead to activate this sodium-potassium ATPase, lead to more potassium to intracellular in potassium is to go from extracellular or intravascular to intracellular, whatever skeletal muscle or hepatic muscle, and 3 sodium cations will go outside to replace this, because this electroneutrality will be happening when you are using insulin. Insulin will activate this channel. This channel work by just to introduce 2 potassium cation from extracellular to intracellular, and we change this by 3 sodium cation 2 from intracellular to extracellular. And the other pathway for insulin, he will stimulate your adrenergic surge of epinephrine, and this will also stimulate this channel and lead to hypokalemia with insulin intake. Case number 3, we have a 66 years woman with severe diarrhea. Patient came, blood pressure 90/60, potassium is 3, bicarb is 8, hypokalemia, metabolic acidosis, and hypovolemia. I think this patient was a little bit hypotension. And the patient already receives this treatment, given oral bicarb and give IV sodium bicarb. You are giving big mistake now. Don't do this. Please, if you have this and this, correct potassium first, not the bicarb, because the bicarb will do rapid shift to potassium to intracellular from extracellular to, and will worsen hypokalemia, and they will end by cardiac or respiratory complication for your patient. It's clear now, patient 60 years, diarrhea, hypotension, hypokalemia, acidosis, you are given bicarb, you're doing shift for your patient, and your patient will develop a rapid complication of his cardiac and respiratory muscle. Incidentally, you found also your patient magnesium is low from this diarrhea, and nausea, and vomiting also, loss more. Suddenly, code blue having down for this patient. When you are treating him by this, and already with hypokalemia now and hypomagnesemia, this patient came to me, you know now, I am starting by these 2 topics, hyponatremia and hypokalemia, because this risk of complication, patient maybe will die from your management. And will blame yourself, and sometimes you will not discover this. Please, if you see one patient, consult with severe diarrhea, and blood pressure is low, potassium low, bicarb is low, acidotic, and you in your mind to manage acidosis first is a big mistake. You should control his potassium first, to check magnesium, and it checks this patient is emergency or not, treat an emergency for magnesium first and the potassium first, and keep bicarb later until you reach safe target of your potassium and magnesium or normal target. What happened for this patient? Already the patient received IV bicarb and suddenly code blue and cardiac arrhythmia. This is not typical ECG, just start to be wide complex tachycardia, and after that you will go to ventricular tachycardia, then ventricular fibrillations in systole and pulses electric activity and sudden death, sudden cardiac arrest. It's a potassium shift already. Potassium shift, as we mentioned, with adrenergic surge, with yes, we have our patient now. One patient will receive the insulin, one patient caffeine, and one patient insulin, and one patient receives sodium bicarb. This is our iatrogenic management. And this patient goes for this type of hyponatremia. This doctor type of hypokalemia. This is a patient related, and this doctor management. Okay, this for also for mechanism of to give him bicarb. When you are giving bicarb, this enhances, increase the intracellular sodium and increase sodium. Just the same scenario. Sodium increase, sodium, potassium increase. 3 sodium will go from inside the cells to outside the cells to extracellular, and the potassium will go intracellular, will lead to more shift of your potassium. It's the same mechanism as we discussed with the insulin in the last picture. Case number 4, 30 years old man, sudden muscle weakness, 4 limbs, quadriplegic now, sudden, 30 years, sudden muscle weakness, 4 limb, quadriplegic. No medication, no diarrhea or vomiting. Past medical history, none. Blood pressure is okay, 160/80, or a little bit hypertension, pulse 128, and you go when you examine your patient from head to toe, you found this swelling here is got already, it's already swelling. Lab, 1 sodium 141, chloride 106, potassium 2, bicarbonate 24, and this creatinine and this urea, and you are trying to give him 10 millimole per hour for 8 hours, and this acute onset with rapid correction, this will be muscle strength will be recovered 2 hours later, and the potassium this rebound hyperkalemia having for this patient. This thyroid, when you check your thyroid, because your examination suspect your patient with thyrotoxicosis or any thyroid, you send the TSH, I think TSH is enough, or you can have patient can able to do T4 is okay. We have here TSH less than 0.03. This means with thyrotoxicosis or hyperthyroidism, and the T4 already is high, 234. Even T3, 7.8 is too high too. Second step, what we will do? To do this investigation already, the first step I will do urine potassium to creatinine. I think less than 2, 12 divided by 11 around 1. I think less than 2 now. We have now in the diagram, our diagram will go with shift. Okay, acid-base disturbance, we'll see bicarb here. I think no acid-base disturbance, this clear shift. Clear shift. I think bicarb here 24 is okay, not with acidosis or alkalosis. Diagnosis for this patient, sudden paralysis, and with goiter already, and the thyrotoxicosis, and rapidly corrected, acute onset with normal acid base, and urine potassium to create ratio less than 2. My patient is diagnosed thyrotoxic hypokalemic periodic paralysis. Thyrotoxic hypokalemic periodic paralysis is sudden onset hyponatremia with sudden correction. Urine potassium to create less than 2, no acid-base disturbance. This with shift already doing acute onset hypokalemia and weakness due to shift of potassium in 2 cells. Legs, lower limb will be more than upper limb, generally spares cranial and respiratory muscles. Asian men most common population for this syndrome. If you live in Asia, you will find this syndrome is common. And maybe some genetic defect. Thyrotoxicosis lead to the same scenario, same problem of acid-base shifts, this high adrenergic surge. Epinephrine lead to increased sodium potassium ATPase. Already shared, we discussed this before, lead to more potassium from extracellular to intracellular, lead to an end by hypokalemia. And also beta-2 agonist also lead to beta agonist stimulation, the same scenario lead to shift of potassium to intracellular by activation, sodium, potassium, sodium hydrogen, sodium, potassium ATPase channel. Periodic paralysis often triggered by this patient with thyrotoxicosis and any periodic paralysis that's triggered by exercise and high carbohydrate meals. This will stimulate insulin, increase more shift and stimulate more your sodium potassium ATPase channel. Exercise will increase your stress, and this will increase your high adrenergic surge, will go to hypokalemia too. For management, IV potassium chloride, take care from risk of rebound hyperkalemia. You will give your patient potassium chloride to be aggressive in management. Just in 10 to 15 millimole per hour, up to 90 milliequivalent per day. Non-selective beta blocker to just control this high adrenergic epinephrine surge. Can give IV propranolol 1 milligram every 10 minutes up to 3 milligrams. This will control high adrenergic surge and stop this potassium shift, and will try to help your manager. You don't give too much amount of potassium. Now, just potassium, any patient you suspect your potassium shift, just give 10 milliequivalent per hour, 10 to 15, until 90 up to 90 milliequivalent per day. And you can use propranolol if you think your patient with high adrenergic surge, 1 milligram every 10 minutes up to 3 milligram, just to prevent your shift, adrenergic shift in a patient with cytotoxic diuretic paralysis. Just you can go continue beta blocker, non-selective beta blocker in future. When you suspect shift, when my patient came by sudden onset hypokalemia, sudden onset paralysis, weakness, I will put in my mind shift, severe hypokalemia, associated weakness, rapid recovery after I give, this is recovered already after policies of potassium chloride. This will give me alarm this patient with shift. And the rapid recovery, as we mentioned, there is no clear cause of diarrhea, vomiting, or diuretic. Acid-based disorders, as we mentioned before, urine potassium not high, urine potassium to creatinine will be less than 2. Okay, this when you suspect shift. If acute onset, severe hypokalemia, paralysis, rapid recovery after you treat, and no acid-based disturbance, and urine potassium to creatinine ratio less than 2. Our criteria to suspect my patient with shift. As we mentioned before, hypokalemia will check urine potassium excretion to creatinine and metabolic acid base. If no metabolic acid base or potassium excretion to creatinine excretion less than 2 with shift, otherwise will be with loss if more than 2. Our case already no acid-based disturbance and the urine potassium to creatinine ratio around less than 2. I think the patient will shift. Our summary, what is causes hypokalemia due to potassium shift? As we mentioned before, any high adrenergic surge, catecholamines, endogenous stimulants, alcohol withdrawal, stress head injury, subarachnoid hemorrhage, MI, and few chromocytoma, insulinoma, and cytotoxicosis. All this will adrenergic surge to stimulate potassium shift from extracellular fluid compartment to intracellular fluid compartment and will end by more worse of your hypokalemia. Exogenous source, just remember when you are treating hyperkalemia, I give salbutamol, this beta-2 adrenergic agonist, and this, especially in patients with bronchial asthma and sulfidation, and also dopamine for heart failure, and some decongestants already, and vitamins, and caffeine, as our case discussed already, and the patient on cyphenols. All this will enhance your adrenergic surge and catecholamine release, and this all will end by shift the potassium from out cells to inside the cells and decrease the potassium intravascular hypokalemia and more worsening your case. Insulin, especially repeating syndrome, will stimulate insulin secretion. When you are giving insulin to treat our patient, like our patient DKA or hyperosmolar state, or a patient given PCL with D5 water will stimulate insulin, and the insulin will end by activate sodium potassium ATPase, and this lead to more potassium. More hypokalemia from potassium shift from out the cells to inside the cells. Also bicarb, by the same mechanism, sodium potassium ATPase will lead to worsening your hypokalemia and this raw shift. All this shift, catecholamines, insulin, and bicarb, hypokalemic periodic paralysis, either familiar or non-familiar, cytotoxic or spontaneous, all this will lead to also hypokalemia with shift. Anabolism, any patient with pernicious anemia receiving B12, or patient already with barium sulfide, they just giving shaving cream, and he's swallowing this cream, especially prison patient, person, and he will came you paralyzed, just you think, and he's just sniff this or swallowing these creams. This shaving cream just will block the potassium channel blocker and lead to more worsening of your hypokalemia through shift. This is our part to cover this part of hypokalemia secondary to potassium shift from extracellular fluid compartment to intracellular fluid compartment. And I think this is so much for shift. I need you to review this presentation one or twice, and I'm sure you will not forget this cases in your future and when you manage your patient. and ان شاء الله نحاول نخلص الموضوعات باقي الهايبوكاليميا ان شاء الله في محاضره قادمه عشان ما نطول على حضراتكم وعلى حسب الوقت عندكم، والله المستعان. ونشوفكم ان شاء الله قريبا مع الجزء الثاني من الهايبوكاليميا، وان شاء الله نحاول نبسط الجزء الثاني بحيث نحاول نوصل للمريض تشخيص good management and good treatment for our patient without any complication, with good diagnosis and good management for our patient. والسلام عليكم ورحمة الله وبركاته. ولا تنسوا الصلاة والسلام على حبيبنا محمد صلى الله عليه وسلم، ونسألكم الدعاء بالتوفيق والسداد، ونلقاكم قريبا في باقي أجزاء الهايبوكاليميا. إن شاء الله ما تحتاجوا تقروا من أي كتاب ثاني ولا تبص في أي كتاب ثاني، حاول تجيب كل الكلينيكال ازاي تتعامل مع المريض. حبيت تقرا الحب لو عايز تطلع في السيولوجي او الباث فيسيولوجي more details as you like, but already I give you the summary or conclusion of hypokalemia and hyponatremia before. No need to look for any other books. And this is my plan or my target. When you confront any patient or you are in front any patient with hypokalemia or hyponatremia, you should do good management to your patient without complication to your patient, and easy to remember, not only just reading from books and after that you will forget that. Hear many presentation before for hyponatremia and hypokalemia, just 24 hours, it will be lost from your brain. But I am trying to fix this cases or critical topic in your mind, and I hope you will not forget my topics forever. And I hope it will be helpful to your management, to your patient. ودايما نسألكم الدعاء بالتوفيق. لو افتكرتونا وانتم بتعالجوا في اي حاجه اقول بس انا ما اطلب منكم شيء غير الدعاء بالتوفيق والسداد، وربنا يكرمنا جميعا ان شاء الله، ونشوفكم على خير باذن الله. والسلام عليكم ورحمه الله وبركاته. نلقاكم قريبا في رعايه الله.